Welcome, everybody. Health Equity Network webinar, the time of the year where we invite members of the network to come and present on the work that they're doing in different parts of the country. And we've got three fantastic presentations, which are quite contrasting as well. In a moment, I will introduce Fiona Marshall, I am introducing Fiona Marshall, who's a research fellow at the National Institute of Health Research. And Fiona at the University of Nottingham, Fiona's going to talk about mobilising evidence to address health inequalities through the Knowledge for Public Health programme. After Fiona's spoken for 10-15 minutes, we'll allow some time for questions. And then we'll follow on with another presentation about the Economies for Healthier Lives work in Salford. Chris Dabbs, Chief Exec of Unlimited Potential, and Orla McCann, Project Manager at Unlimited Potential. We'll talk about how local economic development strategies can be leveraged to improve health, reduce health inequalities, and create a fairer, greener, and healthier economy. 10-15 minutes, and then time for some questions after that. And then we'll have Lauren Tobias, who's Chief Exec at the Volunteer Centre in Hackney. And Lauren's going to talk about Together Better, resident-led engagement programme based in GP practices across the City and Hackney in London that supports community activities to improve health, reduce isolation, and build better local connections. So three fantastic projects, contrasting projects as well, I'm sure you'd agree. So I'm going to invite Fiona, if you'd like to come on, share screen.
Yep, sure. My name's Fiona Marshall. I'm Research Fellow located at the University of Nottingham, and I work full-time with the Knowledge Mobilisation for Public Health study, which is led by Dr. Liz Such, who can't be here today, so I'm filling in for her. Our work is basically about how we use evidence in various forms of evidence and how that is translated and disseminated and used to inform policy and practice amongst local authority, mostly public health practitioners, but also we work with planners. So this is our team members, and we liaise with a number of universities, mostly in the north, both the universities of Sheffield and Doncaster Council as well. And we also have a strong link with Afruka, who form the basis of our public engagement group. So a summary of what we're doing, because it is quite complex in many ways, is that we're the first public health knowledge mobilisation team for local government. Our work is all about meaning making, and as part of that, because several of us also have an arts background as well as a research background, we engage in creative activities as a way of promoting equity and also engagement from multiple stakeholders. We are concerned with health inequalities. That is at the core of our work. And we also engage in various approaches, including co-production. Our work is about responding to the needs of local authorities. So any local authority across the UK can approach us and come to us and say, we have this issue, we would like to do some work and explore this, can we do that with you? And so we start a process of collaboration and also in-depth work. So these can be what we call 3 to 6 month rapid responses, or indeed we have also deep co-production responses. Since the writing of these slides, we've also established an extra 2 years funding on the back of this, so we will be able to do a lot more of the deep co-production work, which lasts up to 18 months with an individual health local authority. So this is our working definition of what knowledge mobilisation is. We see it very much as a dynamic process, and one in which we aim to gently challenge assumptions and help decision makers make the best decisions they can with the evidence that they have. And the evidence that we use is research evidence, such as produced by the NIHR and funded by the NIHR. It's also expert knowledge from practitioners and also lived experience knowledge. And tied in with that, we very much focus on local knowledge. So it's got to be relevant to the local context. These are our rapid projects that we've completed in the past few months since last April when I joined the study. We've completed one in Lincolnshire that was interesting and looked at employee health and well-being and also workplace stress amongst public health practitioners. And we ran a couple of workshops with them using creative methods, and that went very well. We used Lego Serious Play for that, and we helped them draw up a new framework with evidence in liaison with public health practitioners and human resources. We've also worked with Hertfordshire on air quality, and they wanted to very much develop and maintain their almost citizen science and champion networks in communities, and that's ongoing. And within Kent, really this was a project that Liz undertook where we focused deliberately on children and young people's mental health. And it was used as a way of confirming their commissioning process and also the decision making around recommissioning new services that were evidence-based. So here's a little video.
We are Knowledge for Public Health, or KNOPH for short. We offer rapid evidence support for local government. Our rapid projects are 3 to 6 months long, and this is what you can expect. First, we start by establishing a connection with the key people in a local authority. We discuss the topic of interest, the local area, and the evidence need. Second, we look more closely at the issue, which may be, for example, mental health, housing or air quality, and search NIHR evidence that addresses that issue. Working in collaboration with local authorities, we learn about their population, priorities and challenges. This gives us a better understanding of a place and how we can help. Third, the KNOPH team go away and search, sift and select evidence. We provide support such as informative maps, videos, summaries and interactive digital outputs depending on the project. An evidence board looks like this one. Once local users have looked at the summary evidence, KNOPH come to the local area and engage in a deep dive face-to-face workshop. And this is where we work together to make sense of the evidence using design methods. Importantly, we bring research findings together with local knowledge. Finally, we write up the workshop and hand over the final phase to the decision makers. This can be used for some of the outputs of a local government, such as strategies, plans, health impact assessment, practice guidance, job descriptions, or commissioning services. We can adapt this process to meet your needs. Just contact us at this address.
Okay, so all these materials are on our website if you need to look again, and our outputs as well. With regards to the deep co-production projects, we're currently working on housing planning and health impact assessment, which, as I'm sure you can appreciate, is quite complex. There's quite a lot in that. And at the moment, we're working with Leicestershire County Council and also their borough councils and Knowsley District Council. And in particular, what we're working on is the evidence and experiences of planning, which includes the town plans and the ways in which that can help to inform planning decisions for housing developments. Coupled with that, we also got a steer that they would like to embed health impact assessments within planning and housing decisions. So this became quite complex, and we have found actually that, as with many of this work, what's the initial issue very often proves with further exploration and questioning isn't what they actually want or need. And so we have been through a process of morphing this so that we're actually going to try and include developers in this work as well. So this is an example of simple hex, which is produced on Genially. What we feel is that it's important that local authorities develop the skills for presenting accessible data, and we feel that if local authority practitioners are able to use ArcGIS, which many are, there are other pieces of software which are comparatively cheap and can be used for them to use amongst their own communities. So this is our example of housing and public health, in which we looked at these areas that were identified by the local authorities as particularly important to them. Clearly, it's not comprehensively covering absolutely everything, but these are the areas they wanted to look at. So basically, you can just click, and we use storytelling to provide some context within that based on the evidence. So the stories themselves aren't made up from scratch, they're actually based on evidence-based research that's been peer-reviewed. The majority of this is NIHR research, and so somebody who then wants to look at the research evidence and say, well, where's this come from, can do so. We've summarised the research evidence, trying to make it authentic and, you know, as accurate as possible, and then the actual links are down here to the individual open access papers. We don't include anything that isn't open access because we have found that some authorities simply do not have the resources to access non-open access articles. And then here we can click on the outcomes, which will give the outcomes that we would expect from the research that suggests that the individual household level, for the NHS, and also for public health. So that's our hex board. And again, this will shortly be up on our website. We've just got to do a little bit of refining. So as I said, at the core of what we do, we have an equity lens, and we look at the ways in which inequalities can be compounded or not by decision making within public health towards communities. We have a local authority reference group that is composed of mostly senior members of local authorities who help keep us on track and give us advice very openly and often at very short notice, which is really helpful. We use the building blocks of health, or the wider determinants of health, in all that we do. And we're very interested in our PACE group. So that's public and community engagement. The core PACE group are located in Sheffield, but we do have satellite PACE members wherever we're doing our work. So we deliberately try and engage with people with lived experience who are local. And our evidence, we draw evidence with health inequalities in mind, and the types of evidence we use are research-based evidence, often from the NIHR and similar, but also we pull on grey evidence. So we will search for reports, we will search for policy papers, opinions, blogs, and also anything that's out there, systematic reviews, etc., scoping reviews that may have been done internally for local authorities. And that's it, thank you, and I welcome any questions.
Brilliant. Thanks very much.
Okay.
That's an excellent presentation. And I love the graphics on the storytelling as well. And thank you. We have a question, sorry. If I'm away too. I thought someone popped up on my screen there with a raised hand and then it's gone again.
Oh.
I've got a question in the meantime, but if that person wants to come back on, then then do so. Great stuff, Fiona. I was wondering about the part where you mentioned that the work draws on NIHR-funded research, as well as drawing on local knowledge, lived experience, and bringing those research findings together with the local knowledge. Is that a challenge? Because there might be very different types of information and knowledge. Is it a challenge combining that lived experience with NIHR-funded research and so on?
Absolutely. To be frank, we have found, looking through the NIHR research that is being funded, is that often there's a number of gaps in that, in areas that have barely been funded. I must say that obviously the NIHR have focused in recent years more keenly on public health, but a number of those studies haven't yet concluded. And we've also found that there are some distinct gaps. So we have local authorities and people with lived experience saying, well, actually, we want to look at this. We want to look at things like safe neighbourhoods. If you're promoting active travel, we want to know that we're safe. And also that often they feel that the work is not specifically culturally appropriate to their needs. So we do go beyond NIHR research evidence, but again, there are tensions with that. There's tensions between the lived experience, perceptions and views, and also the evidence as it is written. And so I think that this is one of the beautiful things about using creative approaches, is that people can use their imagination. They often feel safe in those spaces to openly share their assumptions and also their thinking on certain things. And we openly work to challenge some of those or discuss them. And we do find that people do change their minds, that decisions and what have you do change. What we're trying to do ultimately is to reach best practice in this at the there and now.
Brilliant. Right, thank you. That's a really helpful clarification. We've got two questions. Linda Jones would like to come on first.
Hi, thanks. Can you hear me?
Hi.
Yes.
Yeah. Okay. Right. A really interesting presentation. And there are a couple of things I'd like to ask as somebody who's been a county councillor. One is, do you do any monitoring of how widely this is used? And the reason I ask is because my experience of being on a county council, which had, I mean, it's two-tier authorities, so the county council had a lot of responsibility, in fact, across Cambridgeshire, is that it has children and young people, it has adults and health, it has communities, mobility and inclusion, and it has highways and transport. All of those are actually public health related. There's one director of public health and a small team. And the relationship between what you're doing and what actually happens, what can be done, what can be achieved in a county council is a really important thing to understand. So what sort of monitoring, if any, are you able to do about that?
We do encourage each local authority that we're working with to devise a mechanism of continuous monitoring and feedback loops on all that they do. We feel that that is really important. Within the No pH study itself, we are building an evaluation arm as we speak that will measure impact. I think one of the things that is potentially a challenge is almost the diffusion across these different, dare I say it, silos of departments and groups. We would love to work with councillors themselves, elected councillors, but we have found that there's been a lot of resistance to that, and we intend to explore that a bit further if we can. It's, you know, we have limited resources ourselves and we have to stick to the remit of our work, but certainly we recognise that there is a real need to have continuous monitoring and to embed public health in everything.
Could I just come
Excellent.
back on that?
Yeah.
I'm not sure we've got enough time, Linda,
Okay.
because we need to make sure we.
Fine.
But pick it up in the chat if you wouldn't mind, and then Fiona will pay attention. And thank you very much, Fiona. Excellent. There are some questions in the chat, Fiona, which if you could just turn to. There's some great questions there, actually. And if we get time at the end, we'll come back to them. Otherwise, if you could respond in the chat, that would be great.
Yeah.
I'm going to move on now and invite Chris Dabbs, Chief Exec of Unlimited Potential, and Orla McCann, Project Manager at Unlimited Potential, to share slides and tell us about the Economies for Healthier Lives work that's been going on in Salford. Chris and Orla, go ahead.
Let me know if that's worked okay.
That's good. Looking great.
Great, thank you. So hi everyone, thank you for having us. My name's Orla McCann. I'm a project manager at Unlimited Potential based in Greater Manchester, and I'm here today with Chris Dabbs, who is the Chief Exec of Unlimited Potential. And I'm going to be taking you through about 10 minutes talking a bit about some of our work in economic development and as a measure of, or as a means of reducing health inequalities. I think we're going to have the questions at the end that Chris and I can take as well. So if you have any of those, you can put them in the chat or keep them for the end. But I'll try and get through this as quickly as possible and cover everything that I'd like to. So for anyone that doesn't know, in Greater Manchester, we did this work in a city called Salford, based in Greater Manchester, and Salford has a really fast-growing economy, probably the fastest growing economy in the northwest of England at the moment, and there are plenty of opportunities here to improve the lives of everyone who lives here. There's so many exciting regeneration plans in place and development that will further change that past image of a post-industrial declining city, which is maybe what would come to mind historically if you thought of Salford, but it is really changing. But it does face a dichotomy. Its current economy is creating what's been locally coined as a tale of two cities. Some people, nearly half the city, are doing quite well, but others are really struggling in that increasing inequality, and it's kind of those same neighbourhoods and same communities that are affected by this increase in inequality. And the wealth now is actually being compared to a place such as Tower Hamlets in London as well, just to give a different picture of that. And kind of regardless of the opportunity that's happening here and those regeneration plans, the benefits aren't spreading equally across the city. And so we're facing a really difficult problem in health inequality, which is only on track to get worse at the moment, unfortunately. And economics, we believe, is at the root of this issue. So we recognise that urgent need for a new economic model to address this. So we are working to create a new economic environment that works for everyone to thrive and to have a meaningful life. And for the past 3 years here, we have been testing a person-centred community wealth building approach, which is co-producing a solution to growing health inequalities in Salford. And this approach redirects wealth back into the local economy and importantly places control and benefits into the hands of local people, which will improve health, reduce health inequalities by providing that agency and a hopeful future for people. And our vision is for a fairer and more inclusive economy, and one that delivers greater social and environmental justice, where wealth is shared more widely across all communities. And based on the 3 horizons framework, we should conserve the parts of our system that is working well, test new ideas and approaches, and work towards a viable future. In terms of the impact then that we are having with this work, we are changing who's involved in economic development. This is local people from some of the lowest wealth areas of Salford that have been involved in this and have been part of co-producing those supply responses to new economic options available for them, and we also now have a lot of greater collaboration between public health and economic development. They are creating new partnerships instead of being quite separate in terms of that local policy and strategy as well. And in last year in 2024, Salford City Council's the corporate plan that they published included their commitment to changing local spend and their commitment to the anchor institution work as well around that progressive procurement element of community wealth building too. So that has been really positive. And through this, we're creating examples of how the economy can work through the creation of social and cooperative businesses and increasing local spend. And through the Salford Local Anchors Network, which we set up in 2023 with 9 public, private and BCSE sector anchor institutions. And we continue to build on these opportunities collectively as well. And actually 2 local people that we worked with on this launched catering social enterprise back in March this year, and this enterprise provides catering to organisations, specifically some of those local anchor institutions that worked with us through this as well, that acknowledged they weren't spending maybe all of the money that they could locally on food and catering, and then thus shifting their spend to a local social business, which also now provides a cafe service to people in Little Hulton and Salford. And if you don't know, Little Hulton is one of the lower wealth areas of Salford. So it was really important that we ensured opportunities for collectively owned businesses were focused here, and gave people from these areas the opportunity to own and control businesses in the area, because we think that ownership and control element's a really big factor in kind of that change in that economic model as well. And local policy and strategy are being refreshed this year, so we have opportunity to have this work reflected in these strategies, and for Salford to commit to shifting the economy and addressing determinants of health and wellbeing. And then we've also been working with Salford City Council through this process, sharing the learning from this approach, and inspiring the inclusion of community wealth building and co-production with local people in the locality plan for health and wellbeing, and the Salford Way strategy to tackle health inequalities, both of which are due to be refreshed and published in the coming months, which is really good timing for us as well. And then some of the key features that we would we feel would create that system change required for an inclusive economy would include commitments to things like co-producing solutions with local people going forward, growing the social economy, exploring alternative approaches to the economy. So yeah, I think that's all that comes to mind from that. I'm really sorry about the slides. I'm not sure what happened there, but if you do have any questions or for me and Chris, please go ahead and ask them as well. Thank you.
Excellent. That's a great presentation, Orla, and Chris to get some of the slides up. So it was working, and we will make the slides available on the network after the webinar this afternoon. So yeah. Excellent. There aren't any questions yet, but I have one. And it is about the work in Liverpool City region, which was pre-COVID, and the work you're referring to was a follow-on to that. At that time, we tended to focus on influencing economic planners in the combined authority on what they were doing. I'm sensing from your work that there's a bit more emphasis on actually working kind of grassroots, changing what people's expectations are from the economies, starting their own businesses. Is that a fair reflection of where your emphasis has been?
Yeah, absolutely. So we know traditionally with community wealth building, a lot of it is with kind of mainly the anchor institutions and those kind of bigger systems. But a lot of the work that Unlimited Potential do in general is with local people, and we want local people to be part of the solutions to kind of any issue around inequality. So this was the kind of start of working with local people around economics for us, and we felt that was really important, because obviously a system that really affects them, and there's so much sort of strengths and skills and passion and drive available in the communities already. So why wouldn't we use that within an economic model that we want to be the benefit to these people as well, and help people to participate in it. And I missed it out of the presentation with all the confusion with the slides, but the Economists for Healthier Lives work that we've been doing led to some kind of spin-off projects as well, and one of those was reimagining the purpose of town centres. Some we're doing now around the economics of a child-friendly city, and some around kind of enjoyable work projects for people as well. So there has been a lot of interest in different areas that have come from like working with public health and economic development around that, but it was really important for us that local people were at the centre of this, and that it's kind of not, we don't need to solely rely on kind of the state and systems to do this. Local people can be part of that solution as well.
And that looks to be a key to the success of the work as well. Well done. We've only got time for one question, I'm afraid. Jeff, try again, and if you can be quick, and Orla, a quick response would be great.
Yeah, great. Okay, Orla, I'm Fiona. There's a link, and that's managing expectations of people in the area after you've been there. And I think from the work you're doing, Orla, there is a large-scale investment. So how does it carry on? In other words, how are the people, tracked in terms of their raised economic spirits? And the same with Fiona. That there is such a huge problem that you're both tackling. How do you, when you've worked directly with people and are getting their experiences and writing them up, make sure that they know how that's being used, and then are you tracking them over time as a database?
So I guess if I've understood it right, the people involved in it, it was a fairly small group as a bit of a pilot for this, and one of the social enterprises was born out of that, the catering social enterprise, and that's currently being incubated by Unlimited Potential through a kind of unique setup that we have, and through that we want to produce that learning back to a system that can then set up maybe an infrastructure to allow more local people to be able to set up their own social enterprises or collectively owned businesses, where that's really particularly difficult, especially for people from lower wealth areas who don't have the kind of set up funds and capital behind them for that. So we are kind of producing ongoing learning as we go as much as possible from that, and that's where we kind of want that policy and strategy change to come in, where the system can then set up something that supports people ongoing. So measurements that we might look at would be kind of a growing social economy, more social and collective businesses in the area, and people telling us or a change in health outcomes, or people telling us that they're happier and feel more hopeful about their lives and things like that. So I'm not sure if that answers the question, but trying to be brief.
That was certainly a good go, and do pick it up in the chat again, Jeff, and Orla, if you could respond to stuff in the chat as well. Excellent, thank you very much. I'm going to move on. Apologies, Linda, just to make sure we give Lauren enough time for the final presentation. So Lauren, Tobias, would you be able to come on and talk about the Together Better project in City and Hackney? Here we go.
Hey, great. Okay, thank you. So I'll start talking. So I'm Lauren. I am from Volunteer Centre Hackney. If you could go on to the next slide, please. Our remit is, as you expect, to support people to volunteer and share skills, and that's our core service. However, we also deliver several specialist programmes, all with the aim of helping people identify and realise their aims, their skills, and helping them to achieve their potential. So I was really interested in the previous presentation. I'd love to see if we could work together in some way. So all while helping people to bring people together as well. Majority of people we work with on these programs have mental health issues and also suffer from isolation. So we deliver a befriending program, employment support. We help people represent their communities and influence statutory services. We deliver resident engagement programs in the community and at GP practices, like what I'm about to talk about, in partnership with public health, NHS, neighbourhoods and housing associations. Next slide, please. So today I'm going to talk about Together Better. So what is Together Better? It's a resident-led social action programme delivered in partnership with City and Hackney Integrated Primary Care at over 38 GP practices. It's led by residents who want to deliver their own initiatives and their own solutions for themselves. So I'm about to describe an example of a GP appointment, which really gives some background as to the majority of our referrals. Next slide, please, and then just keep bringing in the bullet points. So a patient's 54, this is just an example, not anybody we know specifically, attends GP for leg pain and chest pains, is at risk of diabetes and heart disease. The GP prescribes medication, but also identifies underlying but unstated anxiety, depression, exhaustion, and isolation. She's a long-term carer for her husband, was made redundant soon after her children left home. The GP refers her to the social prescriber for additional non-clinical support. She's given a list of community activities. They all look great, but they all require going to somewhere new. The patient says she'll go, really does want to go, but when returns home, the prospect of trying to find how to get to these new venues, it feels really overwhelming. So it's an example of someone underlying health issues at risk of worsening. She's not going out, not doing much exercise, feels trapped through circumstances and poor mental health. The social prescriber's done their best, but the activities she suggests are all out in the community, based at various venues, and of course she has lots of issues, lots of other health issues and other things, and it just feels overwhelming. Next slide, please. So what is Together Better? So as you can see, the biggest words are community, hub, friendship. So what basically it's a programme where patients and residents are supported to attend and participate, and eventually, hopefully, design and lead their own activities. But that's not essential. We currently support about 500 people a week to get to all these different activities. We have about 100 activities a week delivered by over 100 volunteers. We have staff based at all the GP practices where the activities are delivered, which of course feels more comfortable for someone to go to just because they already have a connection with that place and they already know how to get there. And so they're all delivered at the GP practices, and very occasionally if there's no space, at a nearby community centre. And when, of course, that it becomes a hub and it becomes a community because they get to know it, lots of activities are happening, there's a whole hustle and bustle, and the relationships even improve with practice staff. We always start when we start engaging with a practice with a coffee morning and a walking group for patients to gradually get to know each other, for us to get to know the patients, for them to be able to talk really informally about what they like to do, their hobbies and interests. So absolutely no pressure on them at all, but we gradually get to know their life circumstances. Next slide, please. So what are these activities? So here's just some examples of some photos of some activities. As you can see, there's some boxercise, step aerobics. We have an Orthodox Jewish men's exercise group based up in Stamford Hill because we're in Hackney. You can see there's some parties. We also have outings and that the residents themselves want to organise and that they contribute to. We'll always make sure people have relevant training and qualifications if they need, little small grants for materials, but we'll always try and get donations from local shops and corporates as well. The majority of people we engage with, because they're primarily referred by the practice staff, or they're people who have responded to our text messages, have multiple health conditions. They include migrants living in hotels in Hackney, temporary accommodation. We deliver English language classes, all by volunteers. We have an Orthodox Jewish women's class, which they set up, but it took a really long time to engage with them, and eventually we did, which was amazing. And that's specifically for mums of kids with special needs. We're often approached by health professionals who want to find a way to engage with residents of particular demographics in a really informal way. So we'll invite them down to meet people and either to gather some insight. And because they know that we're already engaging with such a wide group of people. Next slide, please. So these are just some examples of some activities. So this is a flyer that's at one of our health centres. You'll see something in there called Mega Ball. I had no idea what that was. Apparently, it's like a space hopper. It's like that big round ball thing that's at the gym that I always ignore because it looks terrifying, and that apparently people sit on to help their core. So that's basically is Mega Ball, where they all jump around. You'll see lots of self-care things, crochet, gardening. There's a lot of gardening groups, exercise, Zoom, but these are all ideas that have been led by residents themselves. You'll see there's English language cancer support groups. So a lot of them have a health focus. which is not imposed by us. Like very occasionally, we do have an external professional who'll come to us and say, like we did last week, saying we really want to tackle more around women's health inequalities. So we've suggested to them to come down, talk about what are the particular issues they'd want to focus on. Do they have a particular demographic they'd like to focus on? But really what we really want is for them to come in and have the women talk themselves about what it is they'd like to do to address these barriers. So the menopause peer support group, for example, was a suggestion by a researcher at a local university. However, it turns out lots of women are quite keen on it and will eventually lead it themselves. So next slide, please. So this is what we do. So we encourage the GP practice to send a text message out, but we also do outreach as well, because especially at the moment, they don't seem to they don't have the money to send out text messages. So and also they don't like sending too many text messages out, which I totally understand. So we also do outreach. We put out flyers. We'll talk to people. So when people will call, the staff will call them back, or they will, and they get in touch with them. And the first thing they'll do is really try to get to know them. They'll encourage them to attend a coffee morning or a walking group, but they really try to identify what is it they need, and they'll make sure that support's personalised. So might be that they need the staff to just call them every morning to encourage them to go and remind them, or to go to their home and meet them at the end of, meet them outside, to go with them. They might need to actually just have, they might need to talk, they might have a neurodivergent condition, they might just be really not keen to engage with anybody just yet, and they want to be somewhere very quiet. So we'll make sure people know that. It's all very personalised. If it gets to the point where they do want to actually start a group, we'll do a little plan with them. We'll make sure they get training on group facilitation, understanding mental health, safeguarding, promotion. We'll maybe provide a small grant to, purchase some materials like yoga mats and do a DBS check. And then once we get going, the staff member might even do it with them a few times and then pull back and shadow them. And of course, the staff will always liaise with the GP practice to make sure that they secure the venue and that they're promoting it. And I have to say that's probably the most difficult part of the programme, but it does work. Okay, next slide, please. So in addition to all the activities, obviously, as I said, and as you know, the people have so many different life circumstances and issues that they start to talk about when they build those trusting relationships. They might never even have talked about it before, or they maybe don't even know that support's available. So we, through our partnership with Hackney Council and with other services, with our mental health services, we invite services down to attend coffee mornings to talk about the help that's available. So we've been able to secure an advisor to come down and deliver advice and be based there for 3 months in several different practices. They've given us over £20,000 worth of, over the last few years, of cost of living vouchers, which we've been able to distribute to people, which I have to say they really appreciate, because they don't have necessarily as many connections and they're not managing to get the funding out. Okay, next slide. And of course, as we know, all these different life issues affect people's health. I mean, I don't need to say that. That's very much was based on the first presentation as well. So many people have housing repair issues that's just unbelievable at the moment, as we know. Okay, so we work very closely with the practices to deliver health and wellbeing events. A lot of the volunteers and the participants who've maybe made things at different activities will display them and sell them. They'll really encourage people to come and see what it is they do at their groups, which of course drives patients to the events, and which the practices will love, because it means that they can start pushing vaccines and blood pressure checks. We will celebrate different awareness days, different festivals. We've trained patients to be digital literacy support volunteers to help patients get online. So it's not just about delivering groups, although obviously that's massive. We really try and encourage the practices to think about ways that we can use patients as volunteers, like on reception or to make calls. But some of the main additional things that we do, which is not just us, but patients too, when they notice somebody is not turned up, they'll call them. And so we've actually helped prevent suicide and crisis. I mean, I don't know if we personally have helped prevent suicide, but we've become aware of somebody's suicidal ideation. We've been able to link them into the GP straight away and get them to call them. We've been able to help, and we have been able to help people use services more appropriately, and also reduce appointments and attend appointments. Okay, so basically these stats say it for themselves. So as you see, this was a survey we did last year, and 80% of people said it had a positive impact on their health and well-being. 91% of people said they created new friendships, and down below are some top 4 health concerns for patients for why they get involved. If you go to the next slide, please. Yes, so this is obviously, as I've said, it has a real positive impact on the GP practice as well. It improves the atmosphere. The GP practice staff, over half, said that they'd seen a decrease in patient appointment requests, and particularly from complex patients. We really try and encourage the receptionists to send us their frequent attenders. It's not always easy for them to find out who they are, but when they do manage, we do, and we have managed to engage with them, which again is not always easy. We have managed to see some definite improvements in how they use appointments. But they've said, you know, that they've seen that they are getting more active, they exercise more, and so their health and well-being improves, and they help manage their conditions. Last slide. Next slide, last slide. So these are just some quotes from some residents themselves who said it's given them more confidence, helped them to understand their capabilities, that they're not alone, they've met people they never would have met before. And some people have really told us, I'm not lying, that this programme has been life-saving for them, because before they got involved with the programme, they weren't going out, they were stuck at home, they're struggling with their mental health, and through the support of both us and the other people involved, they've been able to come along and they've actually seen their life turned around. Okay, that's it.
Brilliant. Well done, Lauren. That was an excellent presentation, great slides. And we will have them on the network this afternoon, so people could follow up and access that video, which did look interesting, and it would be good to see. Thank you very much for that. We've got time for one question. Makbul, are you able to come on screen and ask the question?
Yeah. Hi, everybody. Yeah, Laura, really lovely, because we're actually an anchor community hub in Manchester. And I'm leading on a project at the moment around long-term conditions. Obviously, there's an issue around there around not treatable, but you have to manage it and prevent it. So I'm working very closely with GPs, but I'm just at the initiation stage at the moment. So my question to you was, at the moment, we do a lot of delivery like yourselves activities within our hub, but we haven't yet accessed space or I would say commitment from GP practices around long-term conditions. Because I think what you're saying is great, because the way your volunteers are leading, they're becoming health creating themselves, you know, taking the lead and control of their own health. And that's what we want through this project. So how did you develop that relationship with your GP practices for them to actually give your volunteer leaders space to deliver there? That's my question.
That's not
Is it a long answer?
No, it's a great question, because it's not been easy. It's probably the hardest thing that we've actually had to do, but we just don't give up. We just keep going. We keep going down. We try and attend our staff meetings. We started small. So we started the programme with just 3 GP practices, which were the ones who were the most interested right from the beginning. And then through being able to demonstrate how it works, we got a few more involved and a few more involved. So we gradually built up and up. But we find that obviously, you know, sometimes the practice managers are the most resistant, and it's because it's their space. So we literally just keep going, and I just think it's through the perseverance of my staff, and some of them absolutely love it and they see straight away that they want it, and some don't. So you just can't give up.
That's fantastic. You just can't give up. That's such a good way to bring this to a close, I think. Excellent. And Lauren, there are some really good questions in the chat. If you were able to give some attention to those, and those will be available, you can respond to those after the webinar is finished. Thank you so much to Fiona, Orla, Chris and Lauren for those 3 presentations. It is very heartening to see such good work happening in such different ways in different parts of the country. It really is the kind of thing that we need to hear more often, just to give us all hope and keep going. Please do join us again in a month's time. Last Thursday of June, we'll be having the webinar loosely titled at the minute on wellbeing economies, but we'll sharpen up that title, and please do come back and hear some more about excellent work being done. Thank you also very much for the presentations and for the great questions. See you again in a month's time. Bye.